Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM, WUFO 1080 AM. I'm your host, Francesca Messiah from Kaleida Health, Manager, Workforce Development. And again, I would like to thank you not only for listening, but I want to thank you for when I see you in the community and I ask you that favorite question I've been asking for at least 10 years. Is there a program that you would like for me to air that we haven't discussed? And I appreciate your response. So always be thinking, because I'm out, I know you're out and about, I'm out and about, and you know I'll be asking that question. Well, our topic for today is going to focus on something we don't hear that often about, and that's your vascular health. And as one of the physicians once explained to me, I asked, what's the vascular health? The vascular health is, for lack of better terms, the plumbing in your system. But before we begin our topic today with Dr. Montross, I'm just going to give you a little bit about who is Kaleida. Kaleida Health, we are the hospitals. Buffalo General Medical Center, Oshai Children's Hospital, Gates Vascular Institute, Millard Fillmore Suburban, Visiting Nursing Association, DeGraff Medical Park. We have clinics for adults and children throughout Buffalo and Niagara County. We have an adult clinic called Hurdle Elmwood. It's on Hurdle between Elmwood and Delaware. We have two children's clinics, one on Niagara Street, Niagara Peds, and the other one on Broadway Avenue and across from the Broadway Market. We have two women's health centers. We have one on Kensington Avenue on the ECMC campus, where a bus stop's right in front of that, and Niagara Street. All the clinics that I've mentioned, as well as our two long-term care facilities, one in Buffalo, that's High Point, and one in North Tonawanda at DeGraff, are all on bus routes. So I just want to emphasize that. If there's a show you would like to hear, or you want to share with your class, your church group, your fraternity, sorority, please visit www.kaleidahealth.org/videos. Feel free to utilize the programs of the Great Lakes Health. Kaleida is also available for outreach, speaking engagements, in person and virtual. Also, we are very interested in any upcoming job fairs. We would like to be part of your job fairs and talk about all the exciting careers and growth for growing at Kaleida. If you're interested in working at Kaleida and joining our family, please visit our website at kaleidahealth.org/careers. Again, that's KALEIDAHEALTH.org/careers, CAREERS. Thank you. Well, our topic for today is exciting. It affects youth. It affects adults. Really, I should say, put the reverse order. It affects adults and youth, and it's a topic you can also begin working on while you're a young person, and we're going to talk about that. Our guest for today is Dr. Brittany Montross. Did I say that correctly? Okay, Dr. Brittany Montross. And Dr. Brittany Montross is a vascular surgeon, and she's also the assistant professor of surgery. And she is at both Buffalo General Medical Center and Gates Vascular Institute. Dr. Montross, is there anything else you would like our listeners to know about you before we start with the questions?
I guess one thing to know is I'm a Western New York native, so I've lived here my whole life, and so it's really a privilege to get to give back to our community.
Thank you so much, and that I didn't know. Yay! Here! Cheers to Western New York. Well, our first question: what does the vascular system control in our bodies? Like, a lot of us don't really, unless you've had something go wrong with your vascular. We know about the heart, different things, the lungs, But what is the vascular system and what does it control?
So the vascular system is basically all the blood vessels in your body. So the arteries and the veins. And what they do is, so the heart is there, right? And the heart pumps blood and it pumps blood into your arteries. The arteries deliver blood, which has oxygen in it, to all areas of your body, all the tissue in your body. And that's what, your muscles and your brain and your gut, everything needs blood for it to function, and then the veins drain it back to the heart. So really it is the delivery system, the plumbing, from your heart to all areas of the body and back.
Oh, okay. Well, that's. I mean, I know there are many things we can't do without, but the vascular system sounds like it's like at the top of the flow chart.
Yeah, I mean it's you can't do without blood, you can't do without the oxygen that the blood delivers, and so that gets delivered from your vasculature.
Yeah. Well, okay. So then, why should we pay attention and take and why should we pay attention to this?
So, the couple things that we are basically paying attention to is the ability for your body to give areas blood, right? And so if there's areas that have disease in your blood vessels, so narrowing, or sometimes we'll use words like stenosis or blockages, then you're not going to be able to get enough blood flow to those areas. That can become a problem. And then, similarly, the other thing that can happen is sometimes the vessels become damaged in a different way and they start to dilate or balloon out. And then there's a risk that they could pop. And obviously, if you think about getting a cut and the cut bleeding, you can bleed on the inside too if there's damage to the blood vessels, and that can be a life-threatening situation as well.
Yeah, narrowing is, I know, a term that at least I'm familiar with. What do people narrowing of the arteries? Is that what it means? Narrowing of the arteries?
Yep. So areas in the arteries can narrow down, and then fully kind of block off, or just the narrowing itself can be enough to limit the blood flow to those areas that can cause things to become damaged or even die.
So is narrowing, I'm just going to go stick with the term narrowing. So is narrowing of the arteries, is that something a listener can look at, let's say I don't know, their ankle, their arm? Is it something they can tell, or is it something they need to check with their primary care? And what are some of the symptoms they should be looking for if they think they may have a condition with the arteries?
Yeah, so you cannot see it from the outside usually. If it's very severe, sometimes people would get like non-healing ulcers or wounds on their feet if they had blockages in the leg arteries. But just the arteries themselves you can't see. They're deep on the inside, and so you wouldn't see anything from the outside. But things to look for are, if your muscle isn't getting enough oxygen, it's going to have pain. And so sometimes people would have pain with walking around, and that could be because there's a lack of blood flow, pain in your feet, and similarly, like pain when you eat because your gut needs more blood flow. So it can affect any vessels in your body, but that narrowing can happen anywhere. But pain is kind of one of the first symptoms, and like just like you hear about with the heart, right? Narrowing, and then people have chest pain. And puts them at risk for heart attack. You can have that in any of the blood vessels in your body, but you can't see it from the outside. And so if you have, either predisposing risk factors, such as smoking or high cholesterol, diabetes, those are things that put you more at risk. And so those are things that then you need to be a little bit more concerned and talk to your doctor about it on whether or not, more workup needs to get done to see if there are those areas of narrowing.
Mm-hmm. Is a vascular, is that something like when you go in for your annual checkup? Is that something that either primary care always checks? Is that part of the routine?
It's somewhat part of the routine. So they might feel some areas for pulses, like they might feel for your radial pulse at your wrist. Sometimes they'll listen, depending on your age, to the arteries in your neck, the carotid artery, to see if they can hear a narrowing, feeling for pulses at your feet. But a lot of times it's based on what you tell them. How are you doing today? Do you have any complaints? Doc, when I walk around, I get a lot of cramping in my calves. That should give them an idea that, maybe that's something that we need to look into a little bit further. If you don't have any symptoms, then usually it's not something that needs to be treated anyways, because we treat symptoms. We don't necessarily just treat the disease.
And I think that is so important what you just said for the listeners. It's what you tell them. And many times when I'm out in the community, speaking on different topics or introducing or just speaking or listening, I should say when I'm listening, and people will say they have different, ailments or pain, and I'll ask them, "Did you tell your doctor?" And they'll say, "No, I didn't tell. I didn't tell them." And I always stress the importance of writing something down before you go to your doctor's appointment, and the importance of telling them because it cannot read your mind and tell if you're in pain. And it's always good to tell your friend, but they may not, but they can't help you. They don't have the tools, the stethoscope. They don't have the training to hear if it's your carotid artery. And the carotid artery. Now, where you mentioned that, where is a carotid artery?
The carotid artery is in the neck. So again, vasculature, all the blood vessels. So the blood vessel in your neck, the main one that gives blood flow to the brain, is the carotid artery. There's one on each side. And lesions there, so narrowing there, can put you at risk for stroke.
Mm-hmm. Or how about an aneurysm, a brain?
So brain aneurysms can occur too. Usually those similarly are silent, right? You don't know you have it unless you had risk factors for it, a family history, you've gotten, or an incidental finding, right? You had a head CT after a fall and they noticed something. But unfortunately, a brain aneurysm is usually something that is identified when it pops. And that is treated by neurosurgery. I don't actually do surgery or treat the blood vessels inside the brain. The neurosurgeons do, but.
Okay. And I have to say, and that's the beauty of having Gates Vascular Institute. That's where the vascular physicians and neurosurgeons and the cardiologists all come together because they're organs that are close and related to each other. You're all helping the body in some shape or form.
Exactly. We're all working on blood vessels on the same floor in different areas of the body for sure.
So at what age should listeners begin thinking about taking care of their because it's internal, they can't see it, but what can they do and at what age should you begin to pay attention?
So, in general, the earlier the better. Most of these disease processes do affect older individuals, but it's things that you do early on in your life that can help prevent you from getting to this point. So one of the biggest modifiable risk factors that we have is smoking. Not smoking is going to decrease your risk for many of the things that I treat. I'm hoping someday my field isn't needed because people aren't smoking enough anymore. But yeah, so smoking. So don't start smoking, right? Unfortunately, it still is a worldwide epidemic of smoking starting in schools. But tobacco, cigarette use puts people at risk for blockages, those narrowings. It puts people at risk for aneurysms. And so, not starting is the first thing. And then diet, right? Healthy diet, healthy exercise, making those healthy eating habits early. Again, it's usually vascular disease is a disease of older people, but we're seeing it younger and younger because of issues with obesity and poor choices in terms of your eating, not exercising, and that really does put people at risk. So thinking about it, knowing that it can be an issue, can be helpful. And then we did this, or we've been doing some outreach in some of the high schools, and even teaching high school students about it so that they can take it back to their family and say, you shouldn't smoke, Mom, or, you've been complaining that you can't walk as well, Dad. Maybe it's something that should get looked at. So to kind of have it in people's head to think about it, because again, you don't see it on the outside.
No, no. And I look at, you um more and more uh fast food or food places are having drinks at how about things like sugar? I mean, I think of like some of these drinks where it's sugar and then you have a squirt or something that's sugar and then it's more sugar. I mean, are those types of things good for the arteries?
No, no, I don't think they're good for you in general. But no, and diabetes is a big risk factor for, peripheral arterial disease. It can cause problems in both the big and the small vessels. The small vessels can be hard to treat because you can't, bypass something that's the size of a hair. But it does put people at a big risk of having wounds in their feet. And so really thinking about what you eat and the sugar content can can cause can put you at risk for some of these things as well.
Something that you just mentioned, diabetes, and I didn't realize until working on a outreach event with high school students, I did not realize that dialysis, it's connected through the vascular system, something like that.
Dialysis
Yes,
for kidney disease?
for kidney disease.
Yeah, so the way that we end up involved in dialysis and kidney disease is the way that people are able to receive dialysis is by creating something called a fistula, which is a connection that we create between the artery and the vein, so that people can receive dialysis.
Mm-hmm. Yeah, I didn't realize that. Um, now you talk about younger children and how about vaping? That's something that I think is targeted towards a younger audience. Now, you talked about cigarette smoking, but you didn't talk about vaping. So is vaping just as harsh on the arteries?
So we don't know as much about vaping. It's newer, right? But it can still cause lung disease and it can still cause a lot of damage in the artery. It still has nicotine, and nicotine itself is a lot of the issues are. The tar is an issue too, right? The tar in cigarettes. But just saying, well, I'll vape instead does not decrease your chances of developing these issues.
Mm-hmm. Mm-hmm. Okay. Now, prevention. What are some preventative measures? If someone is listening to this right now, what are some things besides putting down the cigarettes? What are some other things that people can begin to do?
So some of the things that you can do is, and again, it's any blood vessel, so it depends on kind of what we're talking about in terms of overall prevention. But the cigarettes, which we'll beat down one more time because that's the one of the biggest things. But then also your diet, right? Thinking about healthy foods. We live in Buffalo. I love chicken wings too, but if you're eating chicken wings every night, that has a ton of cholesterol and not the good cholesterol. Those like fast food, fatty foods, fried foods lead to buildup of fat and plaque in your arteries that put you at risk for this. So thinking about eating a more healthy diet. Drinking water, staying hydrated is important for some of this, and exercise. So the more exercise that you do, right? So thinking about somebody who has pain in their legs when they walk around because they have a blockage or a narrowing in their artery. Not unfortunately, but the more walking you do, it's actually better. So pushing past that pain sometimes is enough to get you to the walking distance that you need. It actually helps your body build new blood vessels when you're walking around. Your body says, we need more blood, let's make some more.
Let's make some more. Yes. And how about just like I know in some neighborhoods are safer than others. How about like just marching in place? Is that a substitute for let's say taking a stroll in the neighborhood?
Yeah, I mean, if that's what you need to do, getting your body moving, whatever way you can do it is good. More is better, but some is better than none for sure. So walking in place, you're still getting the blood going, getting that heart rate up. That's what we're really looking for.
And I really should say even dancing in place because this is 50 years of celebrating hip hop. And many of us, regardless if you're older, if you're younger, you know some of the hip hop music and you can dance in your home.
Yeah, dancing is probably better exercise than walking. I mean, you really get yourself going.
And years ago, I know there was he wasn't an actor. Maybe he was, I don't know if he was a comedian, but he used to have a exercise video. It's called Sweating. I think it's called Sweating with the Oldies or something.
Yeah.
And they would come out. So old is relative, and you can still do that and sweat, and it'll be good for you.
Yep, for sure.
Yeah, and get a friend to join you. What about okay? I'm thinking of someone who has let's say they have arthritis. Let's arthritis, and they're unable to get up and march around. But if they like just sit in a chair and do different exercises for their legs, is that effective way of exercise?
So, again, if you can't get up and walk around because you have, you can't because of arthritis, anything is better than nothing. Are you going to be able to make more blood vessels grow sitting there and moving your feet? No. But moving your feet, right, getting up and just doing a little bit does decrease the risk of things like blood clots, or issues in the venous system, the veins of developing a blood clot. So, whatever you can do is better.
Yeah, no, obviously, I remember years ago, a friend of mine, her mother would just walk around the table like 50 times or something, because she couldn't get out and walk. So she just took what was in the house. Yeah, and the whole idea, listeners, is just prevention and awareness. Um, Stroke, vascular disease, we know that impacts the African American community. And if it's something that's hereditary and a family member, two or three, has had one of these conditions, diseases that Dr. Montrose is talking about, the whole idea, the whole point of this show is to get is to move and to get moving and so you can get that blood going to the blood vessels and the oxygen. I don't know if that was 10th grade science, 11th grade, but this is nothing new. It's a reminder of what you learned years ago.
Yeah, and I think you said something really important. Some of this is genetic, right? And we do have a higher prevalence in African American communities. And so if you have family members who are diabetics and they have high blood pressure, you could be trying to do everything right, and you still might end up with some of this because sometimes there's risk factors you can't change. But that's where awareness, seeing your doctor, and sharing those concerns, because it's a lot easier to take care of things in the early stages than when it becomes a real emergency.
Mm-hmm. Is there anywhere you would recommend for someone who just tuned into the show as we're talking about vascular health and taking care of your vascular system? Do you have any recommendations where people can go to get additional information?
I mean, you cannot. I think the first thing, right? I mean, there's a lot of stuff on the internet. I don't know if that's always the best source to go to.
Right, exactly.
But I think the first thing would be to talk to your primary care doctor if you're concerned about it, and they would really know if you're somebody that needs to be then referred out to a vascular surgeon. There's some information on our website, UEMD Surgery, but really, I think starting those conversations with your primary care doctor is the first place to start most of the time.
Okay. No, thank you. I know we have a few minutes left, and I know you talked about obesity. And I know I've recently read an article, I don't know if it was in our colitis site or another article talking about obesity in children and how it's on the rise. I know they talked about our clinic that we have that works with families in obesity. How does the vascular system on an obese child, how does that affect their health?
So, obesity is a really big problem. And with obesity, we used to have, right, juvenile diabetes and adult onset. And we're seeing a lot more of that. We've changed the name even, so it's type 1 versus type 2 because we're seeing what used to be considered adult onset more in younger individuals because of obesity and poor eating habits and food choices. And so I do think with that, the concern of having some of these diseases of your blood vessels earlier and earlier is there for sure. And so, with the uptick in obesity, the uptick in diabetes, that's going to result in earlier signs of this peripheral arterial disease or vascular disease in general.
Mm-hmm. Well, in our last few minutes, what are some closing words you would like to share with us?
I think that if you're concerned about your vasculature, you should definitely talk to your primary care doctor. You can always see a vascular surgeon too, but it might be overkill to start there. But if you have concern, again, if it's something that runs in your family, if you have a family member who's lost a limb, if you have a family member who's had an aneurysm or a stroke, or if you have maybe not made the best life choices to start and you did start smoking early, you've been smoking for a long time, you're not the healthiest eater, eating our chicken wings in Buffalo, that getting evaluated early is better than later.
And let's say the chicken wings with chips and French onion dip.
Yep.
They all seem to go hand in hand. Well, Dr. Montrose, I want to thank you for being our guest this morning on the Great Lakes Health radio program. And as I mentioned before, this program, another week or two, will be on the Kaleida website. That's www.kaleidahealth.org/videos. And I think of people who are on their feet all the time, stylists, barbers, even some of the ladies in the church who are ladies and men who are in the church, ushers and health committee. And there's just so many areas or professions that people are on their feet. And I hope that teachers and physicians too. And I just hope that you've learned something, a takeaway from the show to share with your loved ones. And so again, thank you, Dr. Montrose. Thank you.
Of course, happy to be here.
Yes, thank you. And also, I appreciate you for listening. And when you see me out and about in the community, please stop me. Let me know what program you would like to hear. What topic is it that we haven't covered? I want to also share that Kaleida Health, we are open for outreach, speaking engagements, and also I have a new role. I'm now the manager of workforce development. So come talk to me about workforce pipeline to employment. Pipeline to employment is so important for all of us to grow a stronger community. And with our speaking engagements, conversations about workforce or conversations about outreach, I can meet with you in person, or we can have a virtual conversation. And also, please visit our mother-baby unit at Millard Fillmore Suburban. And don't forget about the marathon for you runners out there or walkers. The marathon, the Buffalo Marathon, is taking place at the end of May. Well, enough for that. Any of you take over-the-counter medication for your acid reflux, everything from Prilosec to the generic version of that, Rolaids, Tums. I know many people take this because we all have a tendency to overeat. Well, our guest for today is Dr. Huron Perry. Good morning, Dr. Perry. How are you?
Morning, Fran. It's a pleasure to be here in your program, and thank you for inviting me.
Oh, well, you're welcome. And Dr. Perry is the Chief Division Thoracic Surgery. He's also a clinical professor of surgery and the University of Buffalo Director of Thoracic Oncology at the Comprehensive Center. And that is the Thoracic Oncology Comprehensive Center that's within the Great Lakes Cancer Care Collaborative, which is also part of Kaleida Health. And our topic for today, this is Esophageal Cancer Month, Awareness Month. So we're going to be talking about esophageal cancer and the relationship to acid reflux, to overeating, to taking medication. So Dr. Perry, I'm going to give you the first question. Our first question is esophageal cancer and acid reflux the same?
Yes. Well, it's a little confusing, but definitely they're not the same, although we know that one of the etiology or the risk factor for esophageal cancer is gastroesophageal reflux, meaning what people call heartburn or reflux. As we know, esophageal cancer is nearly double its size today in the last few years in patients with the age of 45 to 64, mainly males. We know that the risk factor are, the males and older males and people who smoke, drink heavy alcohol, overweight, and have reflux. The reflux itself causes changes in the inner layer of our esophagus. And these layers of cells are sloughing and replacing themselves. And sometimes these cells are changing to an abnormal cells, to cells that grow faster and replicate and cause tumor or cancer. And because of that, people who do have long-term reflux are at risk to have esophageal cancer.
Yes, and the reason, part of the reason for this program today, as we talk about esophageal cancer and we talk about acid reflux and we talk about heartburn, is because we just want you to be aware. So, and what's the primary reason and what causes this cancer?
So again, we know it's the changes is really what happened is that one of the cells is changing because of stress. It can be stress because of acid reflux, can be because of any reflux. We have a lot of medication to depress the acid, but they not necessarily depress the reflux. And when this happens, the cells are changing to adapt to this environment that usually are protected. We all have our esophagus go and enter into the stomach just below the diaphragm. And if you think about it, the diaphragm is our stronger muscle we have. Even if we sleep, the diaphragm's still working. And when the esophagus passes through the diaphragm and the stomach is full, it's not going to shoot up all the content of the stomach, whether it's acid, food, bile, everything which we have in our stomach can go back into our esophagus when the pressure in the belly is higher. And if we have the sphincter, the natural sphincter that we are born with, it's not gonna come up. Well, when it comes up, then the lower esophagus is being exposed to this reflexoid, to this fluid coming back from the stomach. Most of us will feel it as a heartburn if it still have acid. But when you depress the acid with medication, you may not even feel it. And you just may witness some coughing, some regurgitation of food up. But our esophagus, when it happens for a long time, our esophagus inner layer kind of adapt to it. And this adaptation creates cells which are not normal cells. And they can have a change, we call it mutation, that cause the cell to become a cancer cell or a cell that duplicate fast, and a mass is being formed as a cancer in the lower esophagus. Now, we will not feel it until it will obstruct more than 50% of the lumen. Think about a hose that can pass water. The water will go through until it be really contracted to at least 50 or more percent of the lumen is being obstructed. Then solid foods, when we start to eat, will be stuck. And this called dysphagia. The food stuck, and this is one of the first warning signs that, something is wrong. But unfortunately, when this happens, it can be sometimes too late. The cancer has progressed so much that it sends metastasis to the lymph node, to the liver, to the brain, and anywhere else. And then it's beyond treatment and beyond cure. So we really want to make sure that we find, if someone develops esophageal cancer, we want to find it early and to prevent it from progressing to stage 3, 4 and kill the patient. So what do we do about it?
Exactly.
Yeah.
What do we do about it?
Yeah. So I wish we'll have like a formal screening program, like we do mammography for breast and x-rays and CT scans for lung cancer. For esophageal, unfortunately, we want to find it before the patient has symptoms of obstruction. So the most general symptoms are heartburn, although we may screen 100 patients or sometimes even 1,000 patients to find one cancer, but then we save this patient's life by finding it early. So in order to treat esophageal cancer, it's better to find it early. And how do we do that? There's a couple of ways. First, we have to treat the reflux. So the reflux we treat not just by the medication, but also sometimes with changing of lifestyle, changing our diet, losing weight, of course. I mean, overweight is one of the main issues to cause reflux. And again, changing eating habits, not to eat before we go to sleep and then lie back and the whole lower esophagus being bathed in our last meal, which is not good. This is very important. And the second thing after that is if a patient has a long-term heartburn and knows they have reflux disease and more depends on this heartburn medication, it has to go and have an endoscopy. Go to the gastroenterologist, have an endoscopy, and make sure there is no any changes in the inner layer of the esophagus. What we do have now, we have new methods now that we can do less invasive than endoscopy tests that go with a small string that the patient swallow, and that can actually sample some of the cells inside, and we send it to a special lab that actually telling us if there's any risk for cancer in the lower esophagus. But this is innovative, this is new, and it's going to be available soon. And we probably going to screen patient next month with these tools.
So then, if a listener knows that they have these symptoms, they know sometimes in the middle of the night they're gagging because it feels like their food is coming up. And you're saying that in a month or so, you may have this screening process. Who would they contact? Would they contact you, their primary care? How would someone even get on a list for a call?
So I think that they should contact our office and the Great Lake Cancer Care general number. We will refer them to our special clinic they will come, or sometimes we also go to the community. I'm not sure exactly the location yet, and do this screening in the community as well. But definitely call our office and call Great Lake Cancer Care.
Do you have the number, or should I have them send me an email and I will forward that number? Do you have a number?
I think the best, we can call the 716-859-7937. That's our office.
Say it one more time, a little slower.
Yes, it's 716-859-7937.
Thank you. And I know we'll mention the number again towards the end of the program. And we talk about lifestyle. And I have to admit, we had the conversation. I used to have bad acid reflux, but I did change my lifestyle, and it's not cured, but it's a lot better. And one thing I found is that through exercise, even something as simple as walking, I felt, and is exercise, does it help with acid reflux?
Definitely. So, any activity which first keep us upright, which is important. The second thing, activity which we have weight loss and changing the inner abdomen obesity and prevent the increased pressure in the belly or in the abdomen to push the stomach and get all the reflux up. It's beneficial to prevent it. This is important. So lifestyle changing, the change of the meals, eat small, spread it, don't eat before you go to sleep, eat healthy. We know that caffeine and alcohol actually can increase reflux, so we'll try to avoid as possible. Completely stop smoking, because this is really, really, really bad for most of the cancer, but especially esophageal and lung cancer. This is important. Sometimes not to wear too compressing clothes. People put use this, girdles and compression on their abdomen. That can also increase the pressure and cause reflux.
Or just tight clothes, any kind of tight clothing around that area. Yeah. And I know one of the things we were also talking about, I mean, we're getting ready to end March Madness, and there's people eating a lot of pizza and wings, and then right around the corner is grilling season. And we know with grilling season, you have your sides to go with it. So you're not saying to cut them out completely. You're just saying either have them earlier and not just have as much.
Yeah, well, I mean, as a physician, as a thoracic surgeon, I do recommend to, get as a few of those as possible, if not to omit the unhealthy diet. I mean, I don't want to scare, but seriously, the esophageal cancer has a devastating toll. There's more than in the U.S. more than 20,000 people die from esophageal cancer, and they're estimated to have a new 20,000 patients every year. I'm not saying it all caused from diet and obesity, but reflux has a significant toll on it, and it's important to know that losing weight is healthier from anything, and eating healthy food is better for your heart. It's better for all the other organs. It will prevent colon cancer, breast cancer, and also esophageal, and it's very important what we eat.
And I just have to add, I did have a friend who had esophageal cancer, caught early, and part of the surgery was they reconstructed his esophagus, which is a muscle. And I mean, he's been cancer-free for years, but that was just a painful process for him as he ate after the esophagus was reconstructed, but he survived. So I just want everyone to know that caught early, as Dr. Perry said, you can survive this. So having the surgery, it will eliminate it altogether. Is that what having the esophageal cancer surgery does? You've rid of that feeling for life?
Yeah, let me elaborate a little bit about about esophagectomy, or removing of your esophagus. So first, it has been changed in the last 10 to 20 years. Now we have a better tool to treat esophageal cancer. For example, like if it's very early, you don't have to remove your whole esophagus. We basically have tools that just remove the layer that has the cancer, and that can cure the patient. So finding early doesn't mean that you have to have your whole esophagus removed. And obviously being followed for life, make sure it doesn't come back, but this is important. The second thing, let's talk about esophageal surgery. That's what I do as a thoracic surgery. Nowadays, our patients are being treated with minimally invasive methods. We're not opening the chest or opening the abdomen. We basically do a small Kier incision. We use the robot in our patients. We reconstruct the esophagus from the stomach, removing most of the esophagus, about 2/3 of it, with the cancer and the lymph node. And sometimes the patient had to receive treatment before surgery, like chemotherapy and radiation, which will shrink the tumor. And when we remove it, it will be a better recovery. I mean, better healing and cure for cancer. When the patient heal from esophageal cancer surgery, usually if we do it minimally invasive and robotic, they average about a week in the hospital, 5 days to a week, and then they go back nearly to their normal life. I mean, it's not any problem with the way you chew, the way you swallow. It's more like changing your eating habits, to change to small meals and spread them, because the stomach that used to be like a big sack in our belly now is a long tube that goes all the way almost to the neck. Nobody knows what's inside. You don't feel that, but you do need to know that you have small meals and spread them. But otherwise, within 4 to 6 weeks, they go back to their normal life and eat normal diet. They just have to change the eating habit. So it's not that complex. It used to be the old school, when they did the esophagectomy in the old way, they used to pull the whole stomach to the chest, and patient had a lot of trouble to adapt to the new constellation. Now, when we do it with the new methods, robotically or minimally invasive, and the patient goes back nearly to normal life within 6 weeks. Yes, so this has really changed. Of heartburn or reflux, well, you definitely, when you take most of the esophagus, they don't feel any more heartburn and reflux. It doesn't mean that they don't have some, but we just follow these patients for life.
Mm-hmm. Something you mentioned, you said that esophageal cancer there's been an increase in men between the ages of 45 and 64. How about women? Has the percentage gone up for women at all?
I mean, I think it's not like this is what's in the last decade since the 90s, but I think we do see more and more women now with esophageal cancer in the last maybe 5 years. I'm not sure what the causing. I wonder if it's related to obesity, to lifestyle. As we know, smoking is going down in men, but it's actually kind of like steady and not going in the same rate in women. I'm not sure, maybe stressful environment, different type of jobs. I'm not sure, but definitely there we see a change.
Yeah, no, because I didn't want women who are, listening to the program to think that that it was only happening. It was only men who were, that was experiencing this.
It's about 3 to 1. I mean, I think about 25 to almost 30% now of our patients with esophageal cancer are women.
Mm-hmm. Yeah. So ladies, we too are at risk if we don't watch what we're eating and our lifestyle and such. So it doesn't just affect men only. What else would you like to share with us about esophageal cancer? And how did you get interested? What was what got you interested in this type of cancer?
Well, I think as part of being a thoracic surgeon and seeing the innovation that's happening in the surgery, attract me to this. When I was a medical student, a patient with esophageal cancer would have the surgery with open incisions. They will open wide the chest, open the abdomen, the belly, and patient will be 2-3 weeks in the ICU, and until they go back to their lifestyle, took months to a year, if ever. I think nowadays with when I trained at the University of Pittsburgh, we did the first minimally invasive esophagectomy at the time. It was fascinating. I know that this is something that we can help our patients. And the innovation that we have now, that we can find it early and even remove it without a major surgery, just endoscopically, it's even more fascinating. And it's more meaningful to help our patients with cancer. It used to be like a death penalty when you have diagnosed esophageal cancer. It's not there anymore. And if we find it early, we can help more and more people and more patients. So that's what fascinates me to do so and to help patients. And unfortunately, now it's still growing, and we're not sure why it's growing. Maybe the lifestyle change, diet change. I'm not sure, but we see, or maybe obesity, that we see more and more. We see more and more esophageal cancer. And I think we need to be ready to take care of all these patients.
Mm-hmm. No, and that's great. And I just want to say that, again, you are part of the oncology team with the Great Lakes Cancer Care Collaborative, which is part of Kaleida Health, ECMC, Western New York Urology. So, and we are a full service cancer facility with oncologists, social workers. We have the whole team. So if you are a patient, you have the same social services, social worker, rehab therapy, treatment. So, support groups, that's all part of the Great Lakes Cancer Care Collaborative, which Dr. Perry is part of. Dr. Perry, going back to phone numbers, if you could provide the number of someone, or someone knows of someone who has this condition and they would like, with acid reflux or heartburn, and they would like to have a conversation with you, what could you provide the number again?
Definitely. 716-859-7937. 716-859-7937. My administrative assistant and my team will be happy to at least address it and send you to the right provider.
Yeah, thank you. And you know what? You mentioned heartburn. What is the difference between heartburn and acid reflux, or is it the same?
So heartburn is the symptoms from acid reflux. Some people had reflux, but they don't feel it because sometimes the inner layer of the esophagus is already kind of like inert to it. It was exploited so much that it's just become scar and you don't feel it anymore. So the reflux itself is the fact that there is stomach content going up into your esophagus, going the wrong way. And the heartburn is the symptoms that we feel when acid is coming up in our esophagus. We feel heartburn. Now, we treat with medication. We treat the acid in the reflex, right, and what comes up, but we don't really treat the reflux. The best way to treat the reflux, if a patient has a chronic reflux issue, is to reconstruct the basically what you talked about before, the muscle, reconstruct the sphincter and bring back the stomach into the abdomen. Sometimes it's just herniating a little bit and create a new sphincter. Basically, we wrap the stomach around the esophagus. It's called a Nissen fundoplication, or a fundoplication that prevent the content of the stomach to go up back to the esophagus. Some people are candidate for that and being seen by us or by our colleagues from general surgery and do this procedure in order to prevent the reflux. And we know preventing reflux can prevent cancer.
Yes, and that was something else I wanted to talk about is screening and prevention. Great Lakes Cancer Care Collaborative is here for you and your loved one. But again, it's we treat the patient, but it's also about education. And we do have speakers who are able to come in, who are in the community actively discussing cancer screenings, and like I said, treatment, how to work with your family, understanding the cancer conditions, and even Dr. Perry. Dr. Perry is more than happy to be part of your program if you ever, to be a speaker. So he's not just here with the Great Lakes Health radio program. He's here for you. He's here for the community. And he wants, and he and we just want everyone to have the information, be educated on the topic and knowledgeable, because I have to say, I personally know of people who will talk about they don't have acid reflux, they don't have heartburn because they're taking an over-the-counter medicine. And how should I respond to that, Dr. Perry, if someone's telling me they don't have this, but we have 2 minutes left. So if someone's telling me they don't have acid reflux or heartburn because they're taking an over-the-counter medication, what should I tell them?
Well, first, if it's controlling, it's fine, but you have to make sure how long are they on these medications. Some of these medications, especially, it's called the PPI, the proton pump inhibitor, the Prilosec, the Nexium. All these medication has side effects, especially if you're taking for many, many years. Osteoporosis, heart side effects. And, you shouldn't, these are not designed to take it for life. So if people have it for a while and they cannot wean it off, I think they should be talking to their primary care or the gastroenterologist to make sure if there's any other options. And if they think that they're a candidate to have anti-reflux procedure, they should be referred to me or my colleague. I have colleagues, my partners in ECMC, I have colleagues here in the minimally invasive surgery division that are taking care of anti-reflux procedures.
And that phone number one more time as we close the show.
Sure, it's 716-859-7937.
Well, Dr. Perry, I want to thank you for being our guest again. You're not a stranger to the program at all, because you always have great information to share with us and share with the community. So I want to thank you again for being the guest today. We have Dr. Yurkan Perry, oncology surgeon with the Great Lakes Cancer Care Collaborative. So I want to thank you, Dr. Perry, for being our guest.
Oh, thank you for all the things you do for the community, and thank you for inviting me. It's always a pleasure.
Thank you. And I want to say that next week you'll hear from my esteemed colleague, and that is Cindy Bass. And Cindy works with EC, Erie County Medical Center, and I know she's going to have a fascinating program. And in 2 weeks, God be willing, I will be back with you with another wonderful guest. And my name is Francesca Messiah from Kaleida Health, Manager of Workforce Development. Bye-bye.